in the interest of everyone's time, why don't we go ahead and get going, and they can join in progress if they're going to join us. So anyway, welcome. Good afternoon. I'm Tracy Walker, the CEO of Journey Found, and I've been asked to remind everybody of the public meeting requirements. Our meetings of the ARPA Transformational Advisory Committee are public meetings as defined by the Connecticut Freedom of Information Act and should follow these guidelines. As this public meeting is held virtually, it will be recorded and made available to view on the DDS website. Committee members must make a good faith effort to state their name and title each time they speak during the meeting. If a committee member would like to speak, please raise your hand and one of us will acknowledge you. There is no public comment portion to this meeting. Members of the public are able to join, watch, and listen only, and can also view on the website. And I'm going to ask Keith to help me watch for who has hands up as we go along the meeting. So the next thing is review and approval of the August 23rd minutes. Everyone received them?
Yes.
Are there any questions, statements, additions? Okay, then motion to, oh, Barry?
Yeah, so I guess I'm not seeing a lot of the meat of what we talked about last time, and I'm thinking about my own comments around making sure that we're gathering, information from other state agencies, making sure that we're not recreating the wheel, making sure that DSS is invited to the table. And those were some of the comments that I made, but I'm not seeing any of that kind of discussion reflected in the minutes. So I just wanted to, and I apologize if I forgot to start. Barry Simon O'Kill.
Already breaking the rules. You're not using the hand. You're doing those kind of things. Well, I think a lot of the future discussions we'll be talking about today, but certainly Keith can make a couple of notations and add that those were added to this month's minutes. And we have agenda item number 5. I think we'll be able to cover some of that piece of things, but thank you. Any other additions or questions, clarifications? Okay. When?
Whenever it's the ARPA Connecticut parent. Along the same lines as what Barry was saying, I think in point E, unless I'm not reading the list correctly, that point E should also have in the final part of the sentence various alternative residential and employment supports because of the day transformation piece as well as the residential transformation piece.
Good point.
Did you catch that, Keith?
Yep.
Okay, thank you. Any other revisions, questions, comments?
I have one.
Yes, Steve?
Discuss briefly having the regional directors reach out to the nonprofits and the other organizations that are providing services, what they're doing, and their ideas and innovations. So I think that's important.
Thank you. Did you catch all that, Keith?
Yep.
Okay, great. Anything else? Okay, so do I have a motion to accept the minutes as amended?
So moved.
I move. I second the motion. Or you're moving?
All in favor?
Aye.
Any opposed? Okay, great, thanks. And I believe next, Cheryl Ellis is going to give us a brief presentation on the DEI considerations we should be paying attention to moving forward. Cheryl?
Good afternoon, everyone. I'm going to try to share my screen, and hopefully you all can see that PowerPoint.
I can see it.
Yes.
Great.
Yeah.
So what I will do is just a brief introduction, starting with I am fairly new to the position, and I started in December 2021. So again, I started in a pandemic. I came from Department of Mental Health and Addiction Services as the clinical director, and I oversaw our diversity committee there, as well as served on the statewide diversity committee. And I hold a degree in clinical psychology and have worked with the gamut of populations, school-age children, young adults, pregnant mothers, um, just the gamut, adults, seniors. So I come with that lens of just we're a vast community, and in every organization I've been in, I just realized how widespread our diversity is. So we come from a diverse community, we come from diverse populations, and I always carry that lens with me. So I bring that to DDS and really think about how to integrate diversity. It's not about diversity is the thing over here in the corner. Inclusion is not the thing over here in the corner. It is really a way to foster awareness and understanding and learning about each other, about ourselves, and what that brings to our community. With DDS, we really are looking to be very collaborative in our diversity efforts. Like I said, I'm fairly new, so there are a number of things that we are planning that are in process. But again, I have grand ideas and people are reeling me in to make them more doable. So the hope is that we will measure the progress as we go along to see what we need to improve, how we need to continue to increase in inclusion across our system. So I have to admit, I did borrow this image because it captured everything that I really feel that we're trying to do as a department. One is being respectful, including all voices, honoring the dignity of everyone's lives, and making sure that they're a part of our community and a part of our discussions. Being in compliance with laws, we are really trying to make sure that we acknowledge human rights and that we are including those in our thought process, building competency in our staff, building competency in our individuals so they can better advocate for themselves. And that's everyone's role. It's not just a few people, it's everyone's role. So I just like graphics. You guys will see that I like to play with graphics, so you'll see different types of graphics in here. But one of the things I wanted to do was assess our landscape. Where are we? What do we have? We were doing a lot already, but there's so much more to do. So some of the things that when I came on, they had training, there's diversity training for all staff. There's opportunities for our self-advocates to have a voice in our programming, in what we do, what we say, how things are implemented. So I came in with that kind of as a backdrop already. Some of the things that came out of those discussions were improved communication. What do our forms look like? Are they outdated? What does each region have that center around diversity? And what education and support do our staff need to make them be more aware and have a better understanding of difference and be more inclusive? So what our current initiatives include are a monthly newsletter. Right now it's internal. I have had a request to have it actually be external and go out to others. There's some steps that we need to take to make that happen. So we're in the process of having that discussion. There's a strategic plan that's been developed to look at what our goals are, what we'd like to have the department move towards in terms of inclusion and creating a community of belonging. and increasing social justice within our communities. We've started already a committee that's reviewing forms and making sure that we're using person-centered language, self-determined self-determined philosophy in all of our language and our paperwork. And we've again started our educational series. We plan to increase that by, again, having this become external, creating forums that family and community members have more of a voice at around diversity, and continuing our educational series to increase awareness of our staff as well. And I am going to. So I started to look at who we work with, and this is just some basic demographic information that I started to collect to really understand the diversity in the individuals in our DDS community. So this is a quick graphic. It demonstrates that we currently provide service to mostly white males, and that we provide service next to a large number of Black males and a large number of Hispanic males. So overall, most of our members in our DDS community are males. In that, do we have anything that's specific to gender? Do we have anything specific in our conversations and our programming that might centered around gender needs or gender differences? So those are the things that when we talk about a DDS community and diversity, what are we looking at? What population are we looking at? What other things may we need to consider? The other thing that I looked at more recently is language. So I took the top 8 languages spoken within DDS. And of course, English was number 1 at 92%. And then we had Spanish and sign language following behind. Then I looked just to see if there were other languages that we really need to pay attention to in terms of translation of documents. And I wanted to know what region, like, does a specific region need to focus on a specific language? And if you see from the graph, we have Polish is actually common in the North region. And do we have documents translated in Polish? Are we making sure that we pay attention to that when we talk about the services and the programming and the events? And this was surprising to me, was the West region had a larger percentage of Portuguese speaking individuals. And I used to work in Waterbury, and I have never even thought about that as a language that we needed to pay close attention to when I was at Demas. But again, when we look at the numbers, granted they're small in comparison to English, but they are something we want to pay attention to when we think about what our next steps are, how we're transforming the system. So those are just some of the data points that we look at. And so in conclusion, diversity to me is collaborative, it's community, and it's really about belonging. So that's the lens I would like us to kind of think about as we think about transformation and what we want to do. And now that we have this opportunity to keep that on the forefront of our mind. So thank you. I don't want to talk much longer, but thank you very much for letting me share my thoughts.
Thank you, Cheryl. Does anybody have a question or two for Cheryl? Some comments? So Shannon?
Hi, this is Shannon Jacobino, the DDS ombudsperson. Cheryl, I think it would be really helpful for this presentation to be done for the individual and family and the DDS engagement committees. I think it's really good information. I mean, perhaps other committees as well, but I know that I'll be asking you to do it for the individual and family engagement committee.
Sure, no problem.
That's a great idea. Thanks, Shannon. Brian Smith?
Yes, good afternoon. It's Brian Smith, Assistant Regional Director, Family Support Division in the South. Just out of curiosity, Cheryl, where did the data come from with respect to the languages spoken and the ethnic backgrounds?
It actually came from e-cameras. Julia Walsh ran the numbers for me along with the help of Wayne, because I wanted to also break out just the regions and those individuals who are active in our DDS system in our community. So it came from e-cameras.
Okay, thank you, because there's other populations that weren't listed that I know are pretty heavy in certain communities. So I was surprised to see them not come up in your top 8, and that could just be a data issue within e-cameras. So
It could be. And one thing, Brian, is that in running the data, there were a lot of blanks, so we had to clean those blanks out. So that is something that I know Julia and Joshua Scarella are looking at in terms of just data entry and cleaning that data.
thank you, Cheryl.
So, Michael? And then Katie.
Michael Bella, parent. Have you looked into coordinating? There is the Governor's Workforce Council DEI committee that's also currently meeting. Maybe there should be some coordination with the DEI provisions that you're looking for. There is a subcommittee for individuals with disabilities, and so maybe we can get you to speak at that committee as well to make sure that we're coordinating, since they're also looking into the DEI aspects of individuals with disabilities.
That would be great. If you want to connect with me, you can send me an email or even in the chat and I can outreach to you.
Right, and I'm on a committee, so I can make that introduction.
Okay.
Katie?
Is Katie muted?
Okay, this is Tracy Walker again. I see a couple other hands, Keith. Who are they?
Kevin Bronson and Barry.
Okay. Go ahead, Kevin.
Kevin Bronson, DDS. I just want to remind everyone that every time you talk, you need to introduce yourself, including you, Tracy, the chair. So please, everyone, remember, because it helps people who are listening that can't see. It's important for people to understand if you are going to say something or have a position on something, for the people that are listening that can't see the box that bounces around, that that they know who said what. And all of us are chairs, so we need to remember to do this at our own committees as well. So thank you.
Tracy Walker again. Thank you, Kevin. And I believe, Katie, have you resolved your audio issue yet? Okay, then we'll go on to Barry Simon.
So thanks, Tracy. Barry Simon O'Kill. Cheryl, thank you for the presentation. And I know I love data, and every time I see it, then start asking more questions. It makes it more helpful. So to that end, just on all of the language spoken and the need to make sure that we have documentation that people can read and understand and all those kinds of things. Just, I don't know if the data was collected in a way that are these bilingual individuals? Was that data at all collected and or considered? Or these people who did not speak English, or English was a second language? So just as far as how the data is collected, certainly I know, I have clients and staff who, for instance, speak Portuguese or speak Spanish, but that doesn't necessitate or mean that they can't access other things. So just having that data is very helpful.
This is Tracy Walker again. Thank you, Barry. Katie, it looked like maybe you were able to access your audio now. I saw her. Okay, we'll go ahead and move on to the advisory committee email inbox. Keith, would that be you?
Yeah. Keith Lavalette, project manager for ARPA. I'm going to share my screen real quick here. Are people able to see this?
Yes.
Yeah.
All right. So everyone should have received an email last week. And this is in regards to actually one of Barry's questions about having being able to upload things to one area, so all of us could look at it. This is the start of a team's over here. It's the DDS ARPA Advisory Committee. There's a file section where people can upload information. And in that, there's some teams information on how to open it and different things about learning this team, about the teams and the uploading and putting information on that. This is fairly new to me, so I'm still learning. I'm just wondering, well, I'm going to be putting my personal email in this so I can see what a guest looks like. There are members, and anybody who has a ct.org address is a member, and everybody that does not is considered a guest. So guests don't have the full potential as a member, but there's not much we can do about that. So this is what we'll be using as we go forward, and people can upload different documents into this area.
This is Tracy Walker again. Peter?
Yes, this is Peter Mason. I'm the director of the ARPA initiative. Barry, this kind of goes right to what you were saying in terms of a place that everybody can put in their information, and it will assist us in terms of what kind of research we're looking for, and if people have their own research in terms of different programs. So everybody can put that on and see these are the different alternative residential or day settings that we're looking at. And people can make comments and stuff like that. So we were trying to use what you said last week and try to use our technology to make this a little bit more interactive.
So this is Tracy Walker again. Thank you, Peter. And Keith, could you stop sharing your screen, please? It's hard for me to, thanks. I think Barry, then Shannon.
So thank you, Barry, Simon O'Kill. And I guess for ourselves, just to be thinking about and making sure that we are practicing inclusion and access. Keith, I don't know what features we will or won't have access to, and our ability to make sure that we can both include information we want and read information that everybody has access to. So just want to make sure that the state isn't treating everybody else differently, and that we do have access to get to the information.
Keith Lavalette, DDS. Yes, Barry, that's my understanding that guests can both add information and look at what's in that program.
Folder. Okay.
Folder. There
Sounds
you go.
good.
Tracy Walker, co-chair again. I think it's Shannon and then Kevin.
Shannon Jacobino, DDS Ombuds person. I believe Kevin Bronson was in front of me, so.
Oh, okay.
Okay. Okay. Thank you, Kevin. So I think it would be great if we could have something like this set up for all the committees so that we could, you know, all of the committees can have a repository for information. Is that possible for you to set that up for us, Keith?
Keith Lavalette, DDS, yes, I suppose it is. I'll, if I, once I get this one up and running, then I can work on the other ones.
Okay, Tracy Walker again. Kevin?
Kevin Bronson, DDS. I don't really want to burst everyone's bubble here. I didn't want to interrupt, but I'm like 95% sure that it only works for internal people, SharePoint. So we might have to look at another option. But again, that's 95%.
So
So I
Kevin,
could
when
be
you're
wrong.
saying, this is Peter Mason, when you're saying that if somebody, if they get onto that site, what do they see as an outsider?
Kevin Bronson, DDS. Peter, we can take this conversation offline. I just had a conversation internally about something like this at the end of last week. So that's the reason why I'm pretty sure it's not going to work. But I don't want to take up the whole meeting. But we could have a conversation, maybe think about something that would work.
All right, this is Peter Mason. Barry, we're working through it. I thought it was one way. We will figure out another method if this isn't the case.
And
Sounds good.
this
Thank
is Kevin Bronson again. I just wanted to Barry, to your point about this sort of stuff. We are working with state documents, and there's state retention policies and what we can and can't put on certain things. So it's kind of, it handcuffs us a little bit, but we can definitely try to work around it to make sure that everyone has the same access.
Tracy Walker again, thank you. Any other questions or comments on that? Okay, I don't see any. So we'll move along to reviewing the draft of the transformation incentives.
Tracy?
Yep.
Sorry, Keith Lavalette, we did have a hand raise, Stephen.
Go ahead.
Yes. If we have, I guess, as Steven Siegelau, I can ask a question. If we already have Microsoft Teams that we use for our own firms or organizations, does that somehow allow us to connect differently?
Keith Lavalette, DDS, I do not believe it does.
Okay.
Kevin, do you agree?
Kevin Bronson, DDS. I don't know the answer, but I tend to unfortunately say probably not. But I don't know, and that's why I think we can internally figure this out. I'm happy to work with the ARPA team and the DDS IT and figure something out for going forward, especially for all the committees, like Shannon said.
Thank you.
Tracy Walker again, and thank you, Keith, for catching Stephen's hand. I didn't see it. Anything else before we move on? Okay, so now reviewing the draft of the incentives for residential and day committees. And Peter, are Pam and Catherine here?
I'm going to go through the residential, and Keith's going to go through the day.
Okay.
This is Peter Mason. Let me share my screen. And let's see. Okay, can people see that?
Yes.
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 Okay. So we've met with both the day and the res advisory committees. And the last meeting we had, we started the introduction of what the incentives will look like, the draft. We've worked through that process, and the committee members saw that they were going to go back and get feedback on those incentives. So these are the incentives we presented to them, but it's not without the feedback. So these are just draft. And as we had said in the beginning, we wanted to try to move this process along. So DDS with the regional ARDs came up with the residential incentives. Now we're trying to get the feedback. So since we presented it to the two committees, now I'm going to bring these to you guys so you have an idea of what we're talking about. Any comments, suggestions will be relayed back to the residential or day committees. So in terms of residential transformation change, these are things that would get paid with an incentive. And so those are any moves that lead to the closing of a congregate setting, moving to an IHS, with remote supports, moving to a cluster IHS. And these are all, some of these are variations of the theme, because what we were trying to do is try to put down all the different options and so that we could prevent some of the questions that we were getting. Yes, I know it's a cluster, but if it's a cluster with technology, is that different? So we were trying to put down all the different pieces. So you may see some of these that they look like repeats, but they have their own little nuances to it. So moving to an IHS, a person living on their own, moving to an IHS with remote supports. So that would be the supports are provided remotely, and the person lives in an IHS. Moving to a clustered IHS, so they're in a setting that has an overnight staff in a clustered area. Moving to a cluster IHS with technology. Moving to one's own home, their apartment, family home, using just electronic face-to-face. Using their own home, apartment, family home, using remote supports. Moving into a CCH, which is a community companion home. Moving to self-direct their residential supports. Moving individuals who have significant behavioral or medical supports off the emergency list and into a vacant bed of a CLA or CRS. So if a provider looks to redesign a group home, so they're going to move 4 individuals who are currently in that house, move them into an alternative residential setting, and then look at providing people who have more significant either behavioral or medical, that would also apply in terms of the incentive. So these incentives have been calculated based on our outcomes, and our outcome is 100 individuals moving out of a congregate setting. If we reach that 100 level, at that point, the money for the incentives at that point will have run out. We would have to work with, I would have to work with DDS to see if there's additional resources that we could use to continue the incentives. If we get to the end of this year, going into next, and we have barely hit any of those numbers, then we may look at adjusting the incentives upwards to give more of an incentives. So we'll be looking at that on a regular basis to make sure that we hit the target of 100 individuals. So here are the incentives. Moving on incentives. So this would be paid to the CLA or the CRS provider. And so they would receive an incentive payment of $33,500 for each individual who moves out of either a CLA or CRS home. It would be one payment that would be made after 60 days of the individual transitioning out. There's a provider transition incentive. So if they have a house that they're looking at and they have 4 individuals and they want to move individuals to a different setting, as each individual moves out, we'll be looking at to make sure that we maintain stability for the provider, so that the incentives would, this incentive would allow us to readjust the monthly amount to match the number of individuals in the house. So if it started at 4, people for a certain amount, and now it goes down to 3, then that same amount would get paid for those 3 individuals. And it goes down to 2, it go down to, so 2 individuals would be paying that same amount from the beginning until everybody's moved out of the house. And then last is the new placement incentive. So this is going to be paid to the provider who's providing the supports. They'll receive an incentive payment for each individual moving into a new non-congregate support setting, and that will be equal to 2 times the standard hourly rate for that support. So, for example, if the individual goes from an individual from a CLA to an IHS program, living in their own apartment, they would receive, right now the standard rate is $38 and something. They would receive $38 regularly, and then they would receive an additional $38 for each hour of support that they have. If they have a safety net, that also would be equal to 2 times that amount as well. That money then is to be used to help in terms of transitioning the individual into the setting, and also to provide an incentive of what needs to be done to help that program. So if we take an example, if we have a provider who has 5 CLAs with a total of 4 vacancies, and one of the CLAs is a 4-bed with 2 vacancies, the individual A has a lawn 5, individual B has a lawn 5 as well. Try to make this as simple. The provider also has a cluster IHS program with 5 participants. Their proposal will be is to move 2 individuals, individual A and B, from the 4-bed CLA to the cluster IHS support program over a 6-month period. And at the end, they'll then close that 4-bed CLA. So they would receive the $33,500 for each of the 2 individuals who move out of the 4-bed CLA. So that would be a total incentive payment for just moving out of $67,000. The provider would be allowed to bill a monthly amount equal to the current monthly CLA authorization for each of the 2 individuals transitioning to an IHS, and that's in order to maintain the supports in the house. And the provider would be authorized for an hourly rate of $77.60 to receive for each of the 2 individuals moving into the cluster IHS support. The standard rate for IHS is currently $38.80. And so 2 times that rate would be $77.60. In addition, they would receive 2 times the cluster net safety net rate for the 7 people. It wouldn't be for the 7 people, for the 2 people, which equals $27,816 per month for each of the 2 individuals. And those incentives will be used to assist with the transition of the 2 individuals for 20 weeks. So how that breaks down for the total, you can see that here, that they would receive a total of $67,000 for the moving on incentive. They would receive to help in terms of the transition over the 6 months, $65,000 addition. Their new placement amount, they would receive $86,000, and then the cluster net, they would receive $111,000. So those are what the incentives were, and we started talking about them, and there's still a lot of nuances that we have to go through. And then there's a number of questions to resolve in terms of, you know, will these incentives make a difference with the providers? Are there other residential settings we should be looking at? How long does someone need to stay in the new setting? If they go for 60 days and they go back to their setting, are they, you know, are they still entitled to the incentive? What should be provided? What should be provided in the provider transitional plan? So as they're coming up with those plans, what should be in there so that we have an idea of what people are looking at doing? What involvement should individuals, families, case managers, regional administrations have in the development of the plans? what should the approval process be? And are there any other centers that can be developed to encourage more alternative residential supports? So that's what we're looking at in terms of incentive for residential. Any
This is
questions?
this is Tracy Walker again. It looks like Shannon and then Greg and a couple of others who I can't see right now. So Shannon.
This is Shannon Jacobino, the DDS ombudsperson. Peter, I'm wondering why for individuals on the waiting list who have a significant behavioral need, I can't remember the terminology that used, but I'm wondering why the incentive is only to move them off the waiting list into a CRS or a CLA, and why other settings aren't included there. I guess my concern is that it sort of perpetuates the idea that people with significant needs can only be served in a congregate setting.
Yeah, no, that's a good point. The issue here is not so much the individuals on the waiting list. The issue is the house itself. And so the incentive is for people moving out of the house. But there is that house that's there, and we have a number of individuals who have significant and behavioral support needs that would be, while they may be good to go into other sections, which may be difficult, but that's not what this transition piece is. This is the providers, trying to begin to start moving people out to alternative residential supports. They have a house that still can be used for other individuals that have some of those significant support needs. And so their choice then is they can close it, or they can look at how they can provide supports to individuals that right now, some of them are on our emergency list and haven't had, and have very little options. Okay.
So this is Tracy Walker again. I think I had the order a little out of order before, so it'd be Michael and then Greg, please.
Michael Beloff, parent. I guess from the standpoint of looking at this, if the goal is to close CLAs and CRSs, perhaps the ones that are underutilized, there might be an incentive for some agencies to game the system a little bit by taking someone from their home, from a CLA, transitioning them out, and then accepting a new person in to refill up that spot. And I think it's great that we're providing the incentives for folks to move out to a less restrictive environment. I think that's the goal here. But I guess the question is this really meant to have a way for agencies to close kind of underutilized CRS and CLAs, or is the main goal to move people out? Because I think that the incentive might be able to be manipulated by agencies to basically get paid to move someone out and then just keep the group environment. And that's okay, because there are people that will be an appropriate environment for. But right now it's a little mushy, and I think that it needs to be tightened up as to what the real purpose is. Is the purpose to move people out? That's the primary purpose, or is the primary purpose to basically find a way to close underutilized congregate settings? And I think it's unclear by how the incentives are set up.
Well, and I think, this is Peter Mason, DDS. I think it's a little bit of both. And I say that because we're looking at a system where we have a number of individuals who have significant support needs that have very little options in terms of the current system now because of the way the system has grown up. And so as people have been in those houses, there may not be the medical support needs or the behavioral support needs in that house, because you're dealing with individuals who years ago, that was the only option. So they have less support needs than than would be required of somebody new going in there. So it's almost putting in a round peg into a square hole in some of these houses. And so if a provider's looking at that and they want to say, okay, you know what? I, you know, I'm underutilizing this, so I'm going to close the house. They can do that. If they're going to look at redesigning that house, they can do that. But what they can't do is move someone else and not do anything that at a house and then say, I'm going to take somebody else. It's like, no, it's like, what do you do? How are you reshaping that so that you're going to provide supports to individuals we have on our emergency list or our waiting list? And that will either be in a in an alternative residential setting or in a redesigned CLA.
Michael Beloff, parent, one last time. I think it would be important, especially as a parent and someone who sits on a board of an agency, what these new revamped residential settings are supposed to look like would probably be important. And it's kind of odd that we're trying to transition folks out before we knew what these redesigned programs are going to look like first. And I guess it's weird to me. It feels like we're putting, not that this shouldn't be discussed now, but it feels like we're putting the cart before the horse. We're talking about moving people out before we understand what those supports will look like, not only for people who are moving out, but for new folks who are starting residential for the first time.
Okay, this is Peter Mason. I will bring that back to the residential committee. Thank you.
This is Tracy Walker again. I think it's Greg McMahon, followed by Barry and Stephen.
Okay, I think this is just a quick question. Scrolling through the list of options that might get an incentive, I don't think I saw supportive living. Is that sort of considered cluster or some other type of service?
Supported living, this is Peter Mason. Supported living or supportive housing?
So, I'm sorry, this is Greg McMahon for DDS. Sorry, I didn't introduce myself. It's supportive housing, I'm sorry.
Yeah, that should be on there. Yes, it should be.
Okay, thank you.
Okay, this is Tracy Walker again. Barry?
So thanks. I want to, I guess, throw out there, I'm concerned that one of the things we should be talking about is, not the incentives on how do we close this kind of thing. To me, it should be, how are we providing vision for what we want the system to be? I mean, if we're really wanting to transform the system, we should be having discussions about, what are the best and promising practices out there? What is DSS willing to pay for on new opportunities? We should be outlining, here's the continuum of care options that we want to create in the system of care so that, parents don't need to worry about where their kids are in the system. They know that they will be cared for and they will be able to move to whatever their current needs are, whether it is in theory up or down, depending on need. And we also need to be, thinking about, as a provider, I have not met any providers who want to enter into this, thinking about how to game the system. Every provider wants to be able to have stability in how they're able to run their agencies. And, I have been a very outspoken critic of the current LON system, making it really challenging to run agencies and have stability in the way the agencies run. And that, thinking about Medicaid as creating a rate that all providers get for whatever service they're providing, and then DDS has the ability to add on to that rate for that service if they want add-on services. But for all providers, it should be, one rate for one service, and I mean all providers, state or nonprofit, that reimburses equally and creates a level playing field. So that to me is what we should be tackling if we want to transform the system. So I'm just, throw that out there. And
Thanks, Barry.
So,
This is Tracy
okay.
Walker. Then, and I guess that's a question we have to make note of. At what point do we match this up with the rates, right? I mean, it's at some point in time, we're going to have to start addressing some of that. Next, I think, is Stephen.
Thank you. Stephen Siegelow. I'm concerned about having shorter term incentives, 5 months or whatever. And then at that point, how do the nonprofits continue to provide services if the reimbursement rate is too low and doesn't cover their costs? Wouldn't it make more sense to have a reimbursement rate that incentivizes the nonprofits to provide the services over the long term, which somewhat follows up, I think, what Barry was saying? So how do we prevent moving people out and then the nonprofits can't continue to provide the services because the reimbursement rate is too low? So that's one issue. And also, how does this apply to people already in IHS in terms of keeping them there? If the agencies can't provide the services because they're losing money, then some of the people in IHS might have to go into more restrictive environments. So there could almost be a reverse flow there, which is clearly not something that we want to happen. So how do we deal with existing people in IHS if the organizations can't afford to keep providing the IHS because the reimbursement rate is inadequate?
So this is Peter Mason, DDS. There's a lot between the two of them. I'm trying to let me just try to gather my thoughts. First off, I know that DDS has been working on the IHS rate. They just recently increased it. I know they're continuing to look at that rate to see other changes that can be made in terms of to enhance that. I think, Barry, while you can go along with one rate for one service for everybody, I think you and I disagree on that, and how that will change the system would be dramatic. That someone who is has less needs than someone else getting the same amount of money is, that would kind of really change how we do things or how things would work, and what the ramifications that would be to the system would take us a while to go through this. And I think, as I said last week, timing in this is what's everything. We've been trying to work through this in the time period that we've given. We're trying to figure out how to maximize the revenue for the system and for our providers as much as we can in the time period we have. So all the things you're talking about, the vision and all that stuff, yes. What we're trying to do is maximize what we have in the short time period we have. And how do we do that? And at the same time, we need to look at the long-term piece. But if we waited for the long-term piece, this money would be gone. Because what you're talking about is going to take us more than 2 years to come up with what that would look like. And so, we're trying to figure out how to maximize what we have. And, when we look at stuff, and every agency has to come at it from their own point of view. Do I wish there was more money in the system? Yes, I do. Is it going to meet every agency's needs? No, it's not. Even whatever system we come up with, unless we paid the highest amount for the highest provider, it's not going to meet everybody's needs. Everybody below that amount will be dancing in the streets, and the highest provider will be happy because they're making their what they have in terms of their costs, but it would be very expensive to the system. And so, how that would play out, we would need to do a lot of analysis in terms of that. One of the things that we are looking at in terms of the transformation plan is, before any of this gets going, is a gap analysis of, okay, this is what you want to do, and this is what your plan is, this is what you're going to do, and what's the gap between where we are now and where you want to be, and is that significant enough, first off, to proceed with the plan, or second enough, is there things that need to be done on the department's part to assist with the provider?
Thank you, Peter. I have Barry, then Wynn, and one question, Stephen, is that a holdover with your hand up, or do you have something additional?
I just wanted to say one thing additional, just to point out that an hour of staff wages is the same regardless of someone's level of need. If someone has a higher level of need, then they may need more hours, but the hourly rate doesn't depend on the level of need. An hour is an hour. So I think that's important. And my second question though was preventing people from going back into a more restrictive environment if the nonprofits can't afford to provide the services. So.
Thank you, Stephen. This is Tracy Walker again. Barry and then Wynn.
So I guess along that same line, what I'm proposing is that we create the continuum of care options so that people, depending on their level of need, go into the right level of care at the right time for the right price. And that's how the system gets designed. And there are actuaries who can help us to know how many people need what levels of care. And then DDS designs the system to have the right amount of slots that meet those needs so that people can move about the cabin, so to speak, and get the right services at the right time. But, I think part of what has happened over time is that people hold on to, lawn resources in ways and game the system in ways because of the fear of losing the ability to get service. But if the system is, once you're in, so to speak, then you're able to move around and you don't have to worry about holding on to, various resources in ways. And we all know that, for any of us, we may have differing needs at different times, but when we go to see our, physician, they don't vary the rate on, which they collect based on what our need is going through. We would get a different level of care based on going through, and they would refer us to the specialist that provides that level of care. So, I think we need to, if we want to transform the system, we really need to be open to providing the vision for that transformation.
Well, and I should have said this from the start. I do have to leave early today. I have a doctor's appointment, so I'm going to let my two co-chairs take over after this. But what I would say, this is Peter Mason from DDS, if I didn't say it, is Barry, I think you've talked about this system, and it would be really good for us to get that in some kind of writing of what that looks like, so that we can start figuring out what that means and how that would actually work in terms of the Medicaid, and whether we need to adjust our Medicaid plan waiver. And we're in the process of looking at doing Medicaid waiver extensions. And so the quicker you can get that and we can start looking at that, that would be great. So unfortunately, I do have to leave. I'm so sorry. I meant to say that from the start. So I will let Keith and Tracy follow through because they are more than capable. Thank you, everybody.
This is
Peter,
Tracy
could you
Walker
sign
again.
too?
This is Tracy Walker again. Thank you, Peter. And I believe Wynn, you are next.
Hi, Wynn Everts, the ARC of Connecticut and parent. I just wanted to point out a couple things. I mean, if you're trying to transform the system and you're going to hand out one-time incentives, these are not like one-time phenomenon in the lives of the people that are being supported. The money should go out through rates, and you should you should work to figure that out. And I guess is what I'm trying to say. The other thing is that I think that as we go down this road, we are going to have to either, take field trips or something like that to see what these other solutions look like. Because not everybody that's supported by DDS lives in an area where cluster apartments are, available. Not, a lot of this depends upon the economics of the underlying real estate market in the regions you're talking about. And that's got sort of maybe it's not the right word, but it's almost discriminatory. So I think that the options, the array, to use Barry's terminology, needs to be very, very broad. And there needs to be flexibility, and there needs to be coherent description of what the things look like. People really need to see them. I mean, as a parent, there are a lot of beautiful places in Connecticut, but I'm not sure I want my son living there, especially if the beautiful place is the middle of nowhere. And, and access to things other than DDS supports should be part of the equation as well. So thank you. Sorry.
This is Tracy Walker. No problem. Nothing to be sorry for. This is what these meetings are for. Stephen, is your hand still up as a relic or? Okay, great. So Keith, I guess now we're going to move on to the day incentives.
Okay, Keith Lavalette, DDS. I'm going to share my screen real quick here. And are people able to see this?
Yes.
All right. So much along the same lines as the residential. We've done the same thing with the transformational changes with the day programs. These are the day changes that would get an incentive, a DSO to GSE, a DSO to full-time ISE, a DSO to part-time ISE and part-time GSE, DSO to competitive employment, DSO to individualized day, GSE to ISE, GSE to part-time ISE and part-time GSE, part-time GSE and part-time ISE to full-time ISE, DSO to self-determination, DSO to transition services, and DSO to project search. The incentives, the amount of money to be awarded has been calculated based on 200 individuals moving out of a congregate setting. Again, if the target number is over or under the estimated amount, adjustments will need to be made. The provider transition incentive, the sending provider will receive an incentive payment equal to the current authorizations to reimburse the provider to maintain supports in the congregate day program for 4 months for each individual. The new placement incentive. Receiving provider providing the supports will receive an incentive payment in addition to the individual's current rate. An individual moving from a DSO to either a GSE, transitional supports, or project search will receive an additional hourly rate equal to the current rate for the new supports provided to the individual for each hour billed up to 30 hours per week for 6 months. An individual moving from a congregate setting to ISE or customized employment will receive an additional hourly rate of $71.50 per hour for each hour billed of ISE supports up to 25 hours per week for 6 months. And here is an example of an agency. A provider has a DSO program with 25 individuals, a GSE with 40 individuals, and an ISE with 14 individuals. The provider proposal is to move 3 individuals from DSO to GSE over a 10-month period. Individual A has a lawn 5, moves in 2 months. B moves in 6 months. Individual C would move in 10 months. We consider everybody as a lawn 5. Then we would move 3 individuals from the GSE to the ISE over a 10-month period. Individual D in 1 month, individual E in month 5, and individual F in month 10. The agency would propose to hire an FTE in ISE and reduce 0.5 FTE in DSO. The incentives, the provider transition incentive. The sending provider would receive an incentive payment equal to the current authorization of 2008 to reimburse the provider to maintain supports in the DSO and GSE program for 4 months. The new placement incentive. The receiving provider providing the supports will receive an incentive payment. In addition to the individual's current rate of 2008, the provider would receive an additional hourly rate equal to the current rate for GSE supports, provided to the individuals for up to 30 hours per week for 6 months for each of the 3 individuals moving into GSE. The new placement incentive, the receiving provider providing the supports will receive an incentive payment. In addition to the current ISE rate of $55, the provider will receive $71.50 per hour for each hour of ISE supports provided to the individual, up to 25 hours per week for 6 months for each of the 3 individuals moving into ISE. And this is just what it would look like, the total incentive payment for moving out of the DSO. It would be $54,206. For the new placement incentive, it would be $40,482. And total incentive payment, or the new placement incentive would be $139,425, and the total incentive would be $234,113. And these were the questions for the day committee. You know, how much of an incentive will make a difference with the providers? Should the provider transition incentive be prorated if the individual splits the program into a part-time employment program? Should this committee consider the sub-minimum wage in making decisions about the incentives? What day settings would be eligible for receiving the incentives? How long does someone need to stay in a new setting? What should be provided in the provider transition plan? What involvement should individuals, families, case managers, and regional administration have in the development of provider plans? What should the approval process be for the plan? And are there other incentives that can be developed to encourage more employment-based supports?
This is Tracy Walker again. It looks like you have a couple of questions, Keith. It looks like Michael first and then Shannon.
Michael Beloff, parent, and I guess, and I had mentioned this last time, from my standpoint as a parent, you know, I think it's, you know, I understand the you know, wanting to move individuals into less restrictive environments in terms of employment and supports. But my concern is that as we move individuals into part-time ISE or competitive employment jobs, they'll be provided less hours of supports. And I think from a design standpoint, you know, which means they're sitting at home if they're only working 12 hours a week, where they used to be a group of supported employment for 30 hours. I think overall, we should have a goal that for day supports, an individual is active and engaged 25 or 30 hours a week, whatever that number should be. That could be in a group employment, it could be ISE, it could be competitive employment, but for the hours they're not at a job, there should be a plan to have them active and engaged, again, whether that's pooling dollars or whatever the plan is, because as a parent, I don't know that I would approve moving my child from an ISE where they're engaged 30 hours a week to a competitive employment environment where they have a 10 or 12-hour job, because that's all that could be found for them. And they're sitting at home the rest of the week. That is not acceptable. Because that's what's happening right now. That's, so I think from the standpoint of looking at this, what is the design and the goal for the individuals who are being served, not just moving them out to least restricted environments where they may be served less.
This is Tracy Walker again. Thank you, Michael. And then I believe it's Shannon and then Barry.
This is Shannon Jacobino, the DDSM Buds person. First, I want to say I agree with Michael's point, so thank you, Michael. The second is I have a comment and a question. The comment is that I do believe that moving people out of sub-minimum wage jobs to competitive integrated employment should be incentivized. DDS is an employment first agency. We're engaged in another process. With the sound committee. And I do think that we have to recognize that, sooner or later that Band-Aid is going to get pulled off, whether it's done here or by the feds or locally, that's going to happen, and that needs to be incentivized. The other thing I had was a question, which is customized employment wasn't on there, and I don't know if that was an omission or if that was intentional.
Keith Lavalette, DDS. I think it was unintentional. That customized employment is part of it, and I do recall seeing it on there. I don't know how it got knocked off. It was an error.
This is Tracy Walker again, Barry, and then Stephen.
So thanks, Tracy. Barry Simon Oak Hill. So I also agree with Michael's comments, and I'm going to say rinse and repeat. So we as a committee need to create the vision of what are the continuum of options that we want to create. The federal regulations, whether you agree or disagree, 14C as we know it is gone, and we need to figure out as a state, are we going to want to support care options that are going to support need options along that continuum, and how is that going to be reimbursed at a rate that is sustainable if those are the care options that we want to have out there as a system of care. And so for me, the discussion is the same. It doesn't matter whether it's day, residential, call it whatever you want. We have to provide the vision for the transformation to the system that we want. And we need to be operating in a way that we create incentives that support rates to providers who want to create those services if DDS wants to buy them. And this needs to be part of the conversation in order to transform the system.
This is Tracy Walker again. Thanks, Barry. And I think it's important to not create a cliff, right? That used to happen to our state welfare recipients all the time. So not to create that same cliff for the provider system. You get the incentives, and then what happens beyond that? Stephen
Siegel, that was really my comment. If you provide these short-term incentives to get someone out into an employment environment, and then 6 months later the incentives dry up, what happens to them at that point? So I think I'm saying somewhat the same thing everyone's been saying.
This is Tracy Walker again, and that would be on, as Barry said, on both sides of this, actually, with any of the services that we're looking at. So I do note that we are running a little short of time, and we have a couple of large items that could take quite a bit of discussion. I'm not sure, Keith, what exactly was the alternative support models discussion supposed to look like?
I believe that kind of went along, Keith Lavalette, DDS, with the email inbox. People had were interested in alternative support models that we may not have discussed already, and being able to let us know what those might be. So once we figure out the email inbox, and then this committee will be able to discuss the alternative supports.
Okay, Tracy Walker, Barry, you had something additional?
Oh, no, I just
Oh,
didn't lower the hand.
okay. All right, well, given that, I'll move on to communication to the stakeholders. Have we, Keith, finalized the consultant yet?
We have finalized the transformation consultant. We have our first meeting. The ARPA team has their first meeting tomorrow with them. So we're hopeful to get that up and running very quickly. The communication consultant, we have not firmed that up as yet. Hopefully we'll know more in the next week or two.
So obviously this is probably one of the most important parts of this whole initiative is communicating to all the stakeholders so that people understand. I think even amongst ourselves, we've struggled a little bit trying to understand what was going on. So, we created a brief laundry list of some of the questions that the co-chairs felt were part of this, but we want to add on to this to make sure that nothing gets missed as far as that. So if you'll bear with me for just a moment, I'll run through those and then we can add to that or expand the discussion as needed. So among the items in no particular order that we need to communicate are: one, who are all the stakeholders? Make sure that they're appropriately identified. What formats get utilized to ensure that the plan is multilingual and incorporates different learning modalities, all of the DEI options. I would add to that what formats are appropriate for which audience, because they might not all be the same. What is transformation and why is it being done? What are the current congregate programs operated by DDS? What alternative residential and day programs do private providers currently provide that increase independence and community integration? What are transformational plans for the providers? How will these plans be developed? What roles will the various stakeholders have in the development of the transformational plans for the individual providers? What are some of the options for an individual or their family who disagree with changes to the person's current living arrangement? How to encourage providers to work together to maximize options for individuals. And with that, I'll open it up for additional suggestions, additions, things we need to consider in the communication plan. Shannon.
Shannon Jacobino, DDS ombudsperson. I think Stephen's point around the sustainability when the incentives aren't there anymore is an important question to consider as well.
This is Tracy Walker again. Thank you. Something else? And it's my understanding that as soon as the communication consultant is on, that they'll be meeting with us because it is part of our role to help guide that plan. Is there any thought about when that might be, Keith, finalized?
Keith Lavalette, DDS. We are looking at one provider right now, but we're just not sure yet if we're going to hire them. So it's
Keith, the Kevin Bronson. I'm going to stop you right there. We're going to the commissioner is looking at it, and we'll get more information.
This is Tracy Walker. Thank you, Kevin. Okay, and then, so are we good to move on to the next agenda item? I don't see anybody else's hand up. All right, and then transformation and the potential effect on the waiting list. More importantly, thoughts about how this is going to be tracked. All right, I know this has been came up in the residential committee and looking at it, and some of the thoughts that have to be given consideration. How are we going to keep that balance as we move forward, as between taking people off the waiting list, moving people into toward more independence and those kinds of things. Barry?
So Barry Simon O'Kill, yeah. So I think this is a really good thing for us to grapple with, because if we're creating, outcome measures that, for instance, if more people are being served in more levels of care with better outcomes, that's a good thing. And if the overall, pot of money, if this is a zero-sum game, then we have to be open to how do we create incentives that open up different opportunities. And one example, I can give is that, again, thinking about programs that are running as best practice or promising practice in other areas. And the one that I've, proposed multiple times to the department is ACT teams. In the DEMIS world, ACT teams work. It's a multidisciplinary program where you have a doc, a nurse, a social worker, substance abuse, vocational education, all those, that team of 14 provide services that, go in and out of people's apartments multiple times a day and can serve up to 50 people. So if the department is spending, $1 million to run that team, and it's providing the right level of care, you're serving a lot more people for $1 million, getting them right level of care at the right time that people need as one opportunity for independence. But we have to be willing to entertain services that are paid for, Medicaid reimbursed in other departments, and be willing to either pilot them or accept them as promising or best practice that is already in existence in Connecticut, that is already being paid for. We don't have to look far. But are we open to, creating those kinds of services, within the continuum of care? Just as an example of the things that we could be grappling with. So more people being served for the same amount of money, but the reimbursement rate is such that it can support it, and providers can make that service, option open to people. So just as an example, that, that could be one, those could be outcomes that we could look at.
Tracy Walker, and it says we have 5 minutes left, Keith. Is that a hard stop?
Keith Lavalette, DDS. We could, usually the recording goes an extra 5 minutes.
Oh, well, yeah, we have just about 5 minutes left, but thank you, Barry. And so what I hear, in addition to the specifics you were talking about, but expanding our measuring just beyond how many people moved out, but what were the outcomes for those people and the others that got to move in behind them as the system shifted. Anyone else have another comment about those? I think too, it's going to create some interesting scenarios with questions about priorities. We've pretty much worked on a Pratt-based system where they make the decisions about who gets what first and those kinds of things. And this is not going to be that same system. It's going to start mixing some of that up a bit. So there's going to be things to think through that process. Wynn? Oh, you're muted.
You're muted, Wynn.
I guess what was on my mind after what Barry said was I apologize. I've completely lost my train of thought. So why don't you keep on going, because we're up against the time.
Okay, this is Tracy Walker again. Thank you. Any other thoughts or comments? This certainly is not the last opportunity for discussion on this. All right. I see. When are you ready to come back, or is that left over? Okay. Stephen.
Stephen Sigalow. I'm one of the few people on the committee that's not either affiliated with DDS or a professional in the field. I'm really looking at it from a parent point of view, but the sense I get is that with this ARPA money, we're looking at throwing money, short-term money, kind of at an existing system rather than, what I think I hear Barry and Wynn saying is change the system so that there's longevity to it and it has legs to it. So that's my concern, is not just throwing short-term money and then being back to where we started as soon as the money is gone, but trying to create something that's sustainable.
Yeah. Tracy Walker, and yes, absolutely. That's an hugely important piece of this, and not totally driven even by DDS. You had other forces behind that too, which complicates it even further. Anything else for the good of the order before we adjourn? Our next meeting is going to be September 20th at 1:30. And I don't see any hands raised, so I think we can adjourn. Have a great day.
Everyone.
Thank you, everybody.
Thanks,
Thank you.
everyone.
Thank you.